Hello, everyone. Thank you for joining us. Today's cancer care virtual seminar topic is colorectal cancer screening. My name is Carmen Boone. I'm an outreach coordinator for the Samaritan Cancer Resource Center, and I will be your host and moderator. This event is brought to you by the Samaritan Cancer Resource Center. We partner with anyone touched by cancer to provide the support they need to live with strength, determination, and hope into the future. This presentation is being recorded, and all microphones are muted and will remain muted during this session. Please use the questions menu to type your questions and comments at any time. Time is reserved at the end of the session for questions and answers. Today, we are proud to have joining us Dr. Kevin Ewanchyna. Dr. Kevin Ewanchyna was born in Saskatchewan, Canada. He is board certified in family medicine in both Canada and the United States. In his free time, he enjoys spending time with his family, reading, physical fitness, music, and theater. Dr. Ewanchyna also serves as the Chief of Medical Officer for Samaritan Health Plans Operations. And thank you so much for being with us today. And I will go ahead and pass the presentation over to Dr. Ewanchyna.
Thank you very much. And I'm just going to be looking for the icon to show my screen. And I'll just be asking Carmen, can you see my screen?
Yes, it's showing up perfectly.
Wonderful. Thank you so much. So good afternoon, everybody. I'm really happy that you're here to join us for colorectal cancer screening discussion, specifically because the month of March is also Colorectal Cancer Awareness Month. So what we're going to be doing today is talking specifically about colorectal cancer and screening options that might be right for you. And Carmen, when I advance the screen, are you seeing that advance?
Yes, it's working.
Great, thank you so much. So I wanted to give a thank you first to the Samaritan Cancer Resource Center for the opportunity to discuss this with you today. And also I wanted to disclose that I have no other disclosures to make outside of being a physician within Samaritan Health Services. So what we're going to be doing today is first that discussion of colorectal cancer, of what it is, also risk factors for colon cancer itself, and then talk about various screening options. And I am going to try to see if I can show both the screen here at the same time as my presentation. Because right now I'm just seeing my screen itself, and I want to make sure that I'm able to see the presentation in front of me. If I can't, you're going to see me going back and forth to the presentation that's on my screen, and we will make it work. So Carmen, I'm going to check with you again. Are you seeing my slides advance here?
Yes, we can see your slides.
Right. Okay, so apologies to those that are viewing. You're going to see my head move back and forth because my presentation is not right in front of me. It's to the side. But what we're going to be doing today for objectives, we want to understand the importance of what really colorectal cancer screening is and address any hesitancies that might be out there. Also understanding there's new updated colorectal cancer guidelines that you might not be aware of. And a little bit about me. Carmen already alluded to the fact that I was born and raised in Canada. I actually practice as a medical officer for the Department of National Defense as well prior to moving down to Oregon with my wife. And I've been practicing with Samaritan 24 years now, and I still see patients clinically in urgent care. What always appealed to me about family medicine was those preventive services and doing as much as we can to prevent disease, not only diagnose and treat disease. That's what brings us to today's topic. Another thing that I'm very proud of, I was serving as the Oregon Medical Association president from September 2019 to September 2021. It's the first time ever that there's been one individual serving for 2 years, and that happened because of the COVID-19 pandemic. But what is colorectal cancer, first and foremost? Well, it's important to understand that it's a disease, first, in which malignant cancer cells form in the tissues of what we call the colon. And the colon is that part of our body that is our digestive system. It removes and processes nutrients from foods, and of course passes waste then out of the body. And very interesting fact, it's the first 6 feet of the large intestine that are called the large bowel or colon. So think of that, 6 feet. It's often the same height that many adults are, or bigger than adults. This is what the colon looks like. And you're going to see my arrow go around from this area here all the way down to this lower side here. So that's what the colon looks like. And colorectal cancer actually comes from years of development from polyps. They might be adenomatous polyps, they might be serrated polyps. And polyps on their own are very common, and polyps will also increase with age. So the older we get, we're unfortunately going to get the potential for more polyps. But very few of these polyps progress to cancer, but they are considered precancerous lesions. And polyps, they're quite large, or have something called dysplasia. It means different cells that are in the biopsy result. Or a villous histology, meaning a lot of villi that are over top of the polyp. These have a higher risk of progression from everyday polyps to colorectal cancers. And the estimate of the time spent in the colon from a polyp that might be less than 1 centimeter size to an invasive cancer is approximately 10 years. So one of the biggest take-home messages from today is colorectal cancer truly is a cancer that can be prevented. For example, if we see these polyps early enough, we remove them, it removes that threat of developing colorectal cancer within that polyp. This is what the polyps look like on the diagram. So this is the inside part here of the colon itself. And you see these little outpouches of tissue from inside the wall of the colon itself. Those are what the colon polyps are. And I like to reduce the stigma of colorectal cancer. So who are some important well-known people that may have had colorectal cancer over the years? And so you see that list in front of you. And the most recent that we might be aware of, Chadwick Boseman, well-known actor in the Marvel Comics movies, and Ruth Bader Ginsburg didn't die of colorectal cancer, but she was treated for colorectal cancer. Sam Simpson, one of the co-creators actually of The Simpsons. So that list goes on, but it's just there to help remind people that there is a bit of a stigma associated with colorectal cancer. That's something we may have caused to ourselves. And these are people, everyday people, and well-known personalities that do unfortunately get colorectal cancer. What are some of the risk factors itself of colorectal cancer? Well, one of them that is known is a family history of colon cancer or rectal cancer. It puts you at a higher risk. Another risk factor is a condition of ulcerative colitis or Crohn's disease, Crohn's colitis. Also, if you had a personal history in your past of colon cancer, rectal cancer, ovarian cancer, endometrial cancer, which is part of the uterus, or breast cancer, it also puts you at a higher risk of developing colorectal cancer. As well, we already discussed the personal history of polyps, those small areas inside the colon itself. And then hereditary conditions. If running in your family are conditions called Lynch syndrome or hereditary non-polyposis colon cancer. These are conditions that create more polyps in your colon than the usual, and it puts you at a higher risk of colon cancer as well. These are some signs that people might see in colon cancer, but it's important to note that these symptoms and signs here that you see listed could be developing in other conditions as well. For example, blood that we see in the colon could be a sign of colon cancer, but it's also could be a sign of having internal, external hemorrhoids. So it's really, really important to discuss these signs and symptoms with your doctor to make a well laid out plan. But other signs and symptoms, a change in bowel movements, diarrhea or constipation, or a feeling that you can't fully empty the bowels completely. Stools that are much narrower than they usually used to be. It's because as polyps grow, they grow inside into the interior of the colon. So then stool coming through becomes more small compared to the usual size of the colon. Frequent gas pains, bloating, fullness, or cramps, or weight loss for no known reason. Feeling of a lot of fatigue. Now, again, this can happen with a lot of other disease states as well, or vomiting. So we always want you to check in with your doctor, nurse practitioner, physician assistant to ensure that you are looking for potential causes of these symptoms. A little bit about colorectal cancer background. It is the third most common malignant neoplasm worldwide. And here in the United States, it's the second most leading cause of cancer deaths. We see that there's approximately 149,000 plus new cases of colorectal cancer that are diagnosed in the United States, and that occurred in 2021. And in calendar year 2021, when this was studied, there's about 52,000, almost 53,000 deaths from colorectal cancer. The incidence of colorectal cancer is higher in men than women, and 78% of the cases of colorectal cancer occur in people that are 55 years and older. But it's important to know 15% of those cases are in that age range of 45 to 54%. And this is why some of those recent guideline changes have occurred. One of the main risk factors is increasing age. We can't do anything about getting older year by year. And also another main risk factor is double that risk with a first-degree relative having colorectal cancer. So if your mother or father, a sibling had colorectal cancer, it increases your own personal risk as well. Why do we talk about colorectal cancer in the first place? Well, part of it is the treatment of the costs associated with colorectal cancer. And this information was taken from the CDC, the Center for Disease Control, and they state that $14.1 billion annual medical cost of colorectal care in calendar year 2010 was realized. It's a large sum of money, again, potentially for something that could be prevented. We also see that 11% of all cancer costs, cancer treatment costs in the United States are for colorectal cancer. And colorectal cancer has the second highest cost of any cancer in the United States. If we look at Medicare spending, age 65 upwards, we see that new diagnoses of colorectal cancer may cost anywhere from $40,000 to $80,000, dependent on the stage. And this was taken from a study in 2013. It might be even higher now. And on average, if you're a cancer survivor, you may have annual losses of work that are due to missed work days, employment disability, and there's a cost associated with that as well, about $1,000 higher compared to people without that cancer history. So some cancer survivors just can't return to full work, or they're not being able to perform all the tasks they once did. So there's a true cost with cancer and colorectal cancer treatment. The United States Preventive Services Task Force came out with recommendations for screening. And they said a grade A recommendation for screening is to really look at people aged 50 to 75 years. And that's a grade A recommendation. A grade B recommendation is to start doing that colorectal cancer screening in age 45 to 49 years. And then there is a grade C. And grade C states selectively screen those patients of yours age 76 to 85 based on their overall longevity of life, based on their other chronic diseases that they have, based on their preference, and based on prior screening history, and then make an individualized decision with that patient. A fresh reminder for people that grade A means that the net benefit to any screening is actually high. A grade B recommendations, there's still a net benefit, but it's a little more moderate. And grade C means that net benefit of doing that screening is actually quite small, but there still is a net benefit. So going back to our previous slide, the net benefit is high in screening adults 50 to 75 years. There's still a net benefit, but it's moderate in screening age 45 to 49, and the net benefit to screening based on specificity and individualized treatment plans for age 76 to 85 is still realized, but it's just small. So these are the current recommended screenings according to the United States Preventive Services Task Force. You can do a high-sensitive guaiac fecal occult blood test. These are like the stool cards of yesteryear, where they were done in the doctor's office. They are still done diagnostically to check to see if there is blood occurring in the stool, but they're more sensitive today than they used to be, and this is why they have the verbiage high-sensitive fecal occult blood test. There's a newer test as well over the last few years, and this is called a fecal immunochemical test, an FIT. There's also Cologuard. You may have seen commercials on the TV. Another word for it is a generic stool DNA test. And this is a test that can be done every year to every 3 years. The FIT tests and the high-sensitive guaiac occult blood tests are done annually. The other current recommendation is a computed tomography or CT scan of the colon, but it's kind of like called a virtual colonoscopy because it's all done with CT pictures. And this could be done every 5 years. Next, a flexible sigmoidoscopy, and this is a light in the camera taking only a look at the sigmoid colon, which is the first, the lower quarter of the colon, rather than the full colon itself. And that could be done every 5 years as well. You could have a flexible sigmoidoscopy, again, that same light and camera, but then it's able to take a look at the entire colon that you may remember from that diagram. And that can be done every 10 years. And there's some recommendations. You can also do an annual FIT testing along with that every 10-year colonoscopy. Or sorry, flexible sigmoidoscopy versus colonoscopy. I erred there in that statement. So the wording is correct on the screen. That annual FIT test can be done with the Flex Sig every 10 years. And then what has become the gold standard, and I'll tell you why, is the screening colonoscopy that's done every 10 years. This is what the fecal occult blood test will look like in the doctor's offices, or you might do some of these home tests at home. But you can see here, this little, looks like a small wooden stick that you can get stool sample on, and then you put it on these packets here. You open up the flap, put the stool on here, you close it up, you send it here in this envelope away for processing. Or it might be a swab that's put into a collection vial that's then sent away to do the testing for blood that's in the stool. This is what the sigmoidoscopy looks like. And sorry about the blurriness of the slide there, but looking at the light and the tube and the camera right here, it just goes to this portion of the sigmoid colon right here. So it doesn't look at this whole other 3/4 of the colon. And then lastly, the colonoscopy. This is again a light and camera, but instead of taking a look at just this part of the sigmoid colon, it's in fact taking a look and doing polyp removal of the entire colon. So whenever we're talking about screening, we have to remember the qualifier about screening. It's for average risk patients. If you are a high risk patient, you don't fall into any of these methods of average risk screening anymore. You fall into a different category. So average risk means you haven't had a diagnosis of colorectal cancer in the past. You haven't had a diagnosis of polyps that have already been removed in the past. You haven't had a history of inflammatory bowel disease, Crohn's disease, ulcerative colitis. There's no personal family history of known genetic disorders that we already talked about, like Lynch syndrome or familial adenomatosis polyposis. So that is a high-risk screening, and that you fall into only colonoscopy. If you don't have those conditions, you're in the average risk screening, which you could fall into that category then of all of those other recommendations that we just talked about. The other screening qualifier, if there's an increased future risk of colorectal cancer because you have already a past history of colorectal cancer, or you've had high-risk adenomas, meaning they're larger than 1 centimeter in size, etc., then you always only fall into colonoscopy as your surveillance. It's not even called screening anymore. You get your surveillance colonoscopy, and thus you wouldn't be able to use FIT testing, for example, or sigmoidoscopy, for example. You only get your colonoscopies. Whatever method of screening is picked between you and your clinician, adherence is going to be key. And adherence can be an overall issue when we look at some of the cost issues with screenings. Also, cost issue can impact people at low income levels, as well as uninsured populations. And so we'll delve into a little bit of what other options are available for people that might fall into those categories. We bring it up because there was a well-developed, well-conducted randomized clinical trial that actually looked at the whole uninsured population, so people in our communities that have no insurance right now. And they mailed the fecal immunochemical test results to their homes, and then did a follow-up phone call reminder to let them know, hey, we've mailed this, and could you please do that test, send it back to us. Well, that phone call after the mail out resulted in an adherence rate, a capture rate of getting 40% of those people sending back in those FIT tests. And that compared to the usual care of just sending them out and crossing fingers and hope that magic happens. And that resulted in an adherence rate of 12%. So we know that following up with our patients is going to be key to ensuring that they're adhering to the screening mechanism that we see fit. There's no best option for average risk people. And the number of life years that have been gained throughout all the recommended screening strategies that we just talked about are nearly the same. Nearly the same. They're not exactly the same, but they're nearly the same. But it does have the caveat. It assumes 100% follow-up. So it means if you pick FIT, fecal immunochemical test, for your testing, you have to do that annually over the next 10 years to try to get the same numbers of life years gained through screening through colonoscopy, for example. So again, whichever method you pick, you stay adhering to that method of screening. You can always move up and down, but don't get away from the adherence of a screening methodology. Colonoscopy is considered the gold standard, and the reason for that is if a specialist, endocrinologist, family or gastroenterologist, I should say, family physician, internal medicine, general surgeon that have been skilled at doing colonoscopy, if they see a polyp that's there at the same time, they can use a little snare in the scope and remove that polyp at the same time. So it's removing that future threat of colorectal cancer. And that's why it's become the gold standard. FIT tests, some of the other issues you might be seeing with it, if you do it just once, it might have a low one-time sensitivity for advanced adenomas. So those adenomas that are getting a little larger. Also, if you have a FIT test or a high sensitive occult blood test that is done and it's positive, you still need then to go towards a diagnostic colonoscopy. Why it's called diagnostic at that point rather than preventive is there's blood that has been seen on the FIT or the high sensitive occult blood test. So then you're using the scope to help diagnose where is that blood coming from. And there can be some impacts on a diagnostic colonoscopy based on your insurance. So insurance carriers may see a diagnostic colonoscopy as having a copay associated with it or a different cost sharing versus a preventive colonoscopy that many insurance companies have 0% copays or 0% cost share because it's considered a preventive service. So there's a little bit of an issue with a diagnostic colonoscopy. Also, the stool DNA with the FIT test, Cologuard, for example, we've been seeing there may be some more false positives in the FIT. And so it gives us some clarity problems with what we do for management of that. What a false positive means, it means that it shows the test is saying there may be colon cancer there or a colon polyp. But when you take a look at the colon itself with the colonoscopy, you see that there is no polyp or colon cancer there. That's an example of a false positive. Also, one of the things needed with Cologuard or a stool DNA test, it requires the entire bowel movement to be evacuated, and then the swab is done of that entire bowel movement versus a single swab of fecal matter that's just on a piece of tissue. Average costs of colorectal cancer screening right now. Fecal occult blood tests or FIT tests can run anywhere from $3 to $40. And a little bit about that variability of price, much like when we go grocery shopping and we see something at Albertsons that's a different price than something at Safeway, that's a different price than something at Winco, that's a different price at something at Fred Meyer, on and on. That variability of who is performing the test gives that price variation. Fecal DNA testing, Cologuard, can run $400, $800. Virtual colonoscopy, that's using CT scanning, can be $750 to $2,000. A sigmoidoscopy could run $2,000 to almost $4,000. And then same thing with the standard colonoscopy. And part of that might be the room and board stay for doing that colonoscopy or sigmoidoscopy in the hospital setting. There might be anesthesia fees associated with that as well. So where are we heading, though, with colorectal cancer screening in the future? And this is not one of the recommended screenings yet, but just to point out that the science is always evolving, and we're trying to find more ways to do proper screening and not miss out on things. And there is actually a blood test that they are looking at that could measure the amount of circulating tumor DNA in a person's blood in their body. So you take a blood sample, and they looked at people ranging age 20 to 89, or sorry, 45 to 84 years of age. The median age was 63 years, and the sensitivity of this circulating tumor DNA from some of our blood samples showed a sensitivity of 96%. And sensitivity means the ability of a test to correctly identify a person with disease. So it means it's a positive test result, and it positively identified colon cancer. That's what sensitivity is. But it's new and emerging. We're going to have to do more study. And it's just to point out that the science always keeps changing, and we have to keep up with that science. It's not a current recommended test, so don't run to your doctor right now and ask for the blood test for colon cancer screening. It's just not available. But talking about testing is important in this age of colonoscopy. Colonoscopy is the gold standard, and it is the most frequently used screening, but there may be issues with ick factor with some people, or they've had poor outcomes with colonoscopy in the past, or they have financial concerns. So it's important to also acknowledge those other tests for screening are available. And again, the statement that if done regularly enough and you're adhering to the screening, the outcomes from lives of or number of years saved with colorectal cancer screening almost gets close to that of doing colonoscopy. Some of the advantages of doing the stool blood testing, so high sensitive occult blood testing or the FIT, it's less expensive. It can be offered by any member of the healthcare team. It doesn't have to only be done by a person that's trained in doing colonoscopy. It requires no bowel preparation. Some people don't like doing the go lightly or the liquid that you have to utilize to evacuate your bowels completely. It can be done in the privacy of your own home. It's not done at the doctor's office. It doesn't require any time off of work, you don't need assistance getting home after the procedure, and it is considered non-invasive. There's no risk of having pain, bleeding, or bowel perforation, which is a known risk factor of colonoscopy. So again, we need to do colonoscopy though if any of those blood tests are abnormal. You can't stay only doing those FIT testings. You have to proceed towards a diagnostic colonoscopy. And they looked at a study in San Francisco looking at 997 people from ethnically diverse backgrounds and found that if they were receiving different recommendations for screening, that if you recommended colonoscopy, for example, about 38% actually completed that colonoscopy. But if you recommended occult blood testing, 67% completed that occult blood test. And if you recommended to them, you can either do a colonoscopy or an occult blood test, again, 69% completed that test. And my bias is it's probably because it was easier to do that than go through the rigor of the prep and the time away for a colonoscopy. Some people too may forego any type of colorectal cancer screening if they're not at least offered the option of doing a home-based screening alternative. Also, the clinical evidence has shown that selecting the annual stool blood testing instead of colonoscopy is a very reasonable and valid option. And people that select stool blood testing have to be prepared to accept that follow-up colonoscopy if the stool blood test is abnormal. If we do the high-sensitive occult blood testings, those are different stool samples done on 3 different days after about 7 days of dietary medication restrictions. So you're going to have to restrict yourself from taking iron supplements, for example, restrict ibuprofen or other NSAIDs that could cause bleeding into the gastrointestinal tract that might be erroneously picked up. Also, food requirements to avoid red meat, for example, that could alter the pickup of the occult blood testing. And those kits are then manually processed in the clinic or at a laboratory, and Medicare pays for that test to about $4.48 to the providers to do that. FIT tests, they're easier because there isn't dietary or medication restriction at all. It's usually just done once, sometimes 2 times. And again, you just send that into your clinic or lab and it is processed after that. The caveat for stool testing, if you're going to pick this route for colorectal cancer screening, is you do not rely on what the doctor or clinician is doing in the office setting. For example, you might be having a screen as well or a evaluation for the prostate and having a digital rectal exam. And the doctor may do testing on any stool that is in the rectal area to see if there's any blood. That is not an appropriate colorectal cancer test. So if you have a clinician that's just doing it in the office and say that's covering you, you need to ask that clinician for the take-home tests that you're going to do at home to send in. There's no evidence that doing the digital rectal examination and stool testing one time in the office setting is sufficient enough or sensitive enough to really look for a colorectal cancer. So other barriers to colorectal cancer screening, they're quite multifactorial. Access to healthcare. We live in rural areas in our area, and not everybody can get into the colonoscopy center. Many have a lack of insurance or appropriate coverage, and it can sometimes be difficult to navigate through a healthcare system. Also, there's cultural barriers. We know that there are different thoughts from a cultural perspective to having testing occurring in the colon. And again, getting to that ick factor. Oh, people don't want their stool tested for anything, or they don't want to have that prep for the colonoscopy. We often see that populations that are at risk that we have to be definitely aware of from a health equity perspective are the uninsured, underinsured people. Also, we know that Black, Hispanic, American Indian, Alaskan Native, and Asian Pacific Islanders populations are screened at a lower rate than white people. And so we have to take that into account for appropriate screening recommendations. Also acknowledging that we may be seeing colon cancer actually occur at ages that are earlier in these populations as well. Again, that patient population at risk, that family history of early colorectal cancer or having polyps, And then younger patients, when we start talking to our patients at age 45 about appropriate screening, this group does have a lower rate of colorectal cancer screening in general versus the overall population. So getting that word out primarily to the age 45 and upwards that they're due is going to be really, really important. So some of the recommendations that we're coming up with right now. Your consideration of colorectal cancer screening approach needs to be tailored with the patient in mind. Talk to them about what they wish to have. Look at the other issues from an equity perspective. Look at their availability of insurance coverage. Consider their race, their family history, their genetics. Also considering those new advances in the recommended strategies. So that change in the United States Preventive Services Task Force recommendation, grade B recommendation now to start screening at age 45. Unfortunately, in our payer landscape, you always have to consider the insurance guidelines that might be there. Colonoscopy screening versus diagnostic colonoscopy. And again, also acknowledge our own individual clinician biases and the biases that our patients might have. The National Colorectal Cancer Roundtable stated that in this time period of the COVID-19 pandemic, a lot of screening strategies have fallen by the wayside. They're now starting to pick up, but we're going to have to do a lot of diligent work to try to catch those people that didn't get appropriate screenings in this COVID-19 pandemic. Again, maintaining prevention is key to everything that we do. And identifying the patients in a stratified way that might benefit most from getting that colonoscopy. Seeing those resources are now is going to be many more people going through a potential colonoscopy route, and we're going to have to start to individualize and prioritize the ranking. Also acknowledging the information that is being sent out that safe screening can occur at home safely with at-home tests. And we need to reignite that public message about the real importance of activities, the importance of public health, the importance of science that's guiding us. Some of the benefits from the CDC about using these proven strategies are we can prevent cancer. Again, colorectal cancer is a cancer that can be prevented by early screening, early diagnosis of polyps, early removal of those polyps. We can increase screening. So if we increase screening to 80% from current levels, we can reduce the number of people that are diagnosed with colorectal cancer by 22% by the calendar year 2030. Also, we can reduce deaths. If we increase screening to 80% from current levels, we can reduce deaths from colorectal cancer by 33% by calendar year 2030. And if we can also increase the 5-year survival rates. So about 90% of adults that are diagnosed with colorectal cancer, actually, if they're diagnosed at an early stage, they will live for 5 years or more, 90% of the time, compared to 14% of the people diagnosed with late-stage colorectal cancer. So early detection of that staging is key. And at the end of the day, we all pay taxes, and it's our taxes that support Medicare, CMS, government-sponsored plans. We can save the government money. If we increase screening to 70% from current levels, we could reduce the Medicare spending by $14 billion by calendar year 2050. And where else could that $14 billion potentially go? So in closing, we now have time for questions. We wanted to give about 40 minutes of the presentation today and then be able to answer any questions that might have popped up during the Q&A that were put into the chat. And we'll open up or pass it back over to Carmen for those opportunities.
Thank you so much. Thank you so much, Dr. Ewanchyna. So let's see. Now we'll give our audience a few moments to write any questions and comments in the questions menu. While you are entering your questions, we'll go over some contact information and upcoming events. So here you can see if you'd like more information about cancer, feel free to contact us at the Cancer Resource Center by phone, email, or visit our website or visit our offices. If you're interested in upcoming events, please contact us to subscribe to our Cancer Resource Center newsletter, or if you have any questions, we are here to help you. If you like to find out more about what is going on and what we're working on, we're gonna have a couple of events upcoming. On Wednesday, March 30th, we're gonna have Let's Talk About Lymphedema. And on Thursday, March 31st, Caring for the Caregiver. To register, check out our latest newsletter and feel free to call us or send us an email. Now we have a Facebook page and an Instagram, and we'll be happy to answer any questions. If you can check our posts over there as well. So now let's go over your questions. Let's see. So we have a question from Wendy. It says, you mentioned that people who've had breast cancer may be at greater risk for colorectal cancer. Please say more about that correlation.
Yeah, there are some genetic syndromes where clusters of cancers may fall together. And breast cancer, endometrial cancer, I'm just trying to find the slide to go back to it. But it does put you at an increased risk. So it means that you just have to be more aware of those screening options. You don't fall into that high risk category that I was talking about before, where you need your colonoscopies regularly. You still could get your screening done through the other methods that we talked about, but it just puts you at a slightly higher risk due to some genetic predisposition of having breast cancer, endometrial cancer, etc., ovarian cancer.
Thank you so much for your answer, Dr. Ewanchyna. And that was our only question. I just can see comments and kudos and thank yous. So if anybody has questions later on, feel free to send us an email and we'll be happy to connect you with Dr. Ewanchyna, or if you have any question that you prefer to be answered privately, we can do that as well. And now let's, if there, sorry. So please keep in mind that once we finish the webinar, we will be having a survey. So please fill in the survey that will open after the webinar has concluded. And thanks to Dr. Ewanchyna for sharing your time and knowledge. Thank you so much to being with us today. And finally, thanks to all of our participants today. Now you may disconnect and you have completed our session for today. Have a wonderful day. Take care, everybody.
Thank you.
Bye.